When we think of psychotic disorders, we usually tend to immediately go to schizophrenia. And with schizophrenia, we think hallucinations. And even though schizophrenia is one of the most commonly diagnosed psychotic disorders, it's not the only one. And it's also within a spectrum itself. There are other diagnoses associated in the schizophrenia spectrum disorder. When diagnosing psychotic disorders, including schizophrenia, there are a set of positive characteristics or symptoms that are pulled from for that diagnosis, while also considering some negative symptoms or characteristics. I'm going to go over some of the positive characteristics. I'm pulling this information from the DSM-5-TR from the American Psychiatric Association. First off is hallucinations, whether visual or auditory. They are extremely real to the individual, but are not prompted by any external stimulus. Also, disorganized thinking. This could be trying to have a conversation and their input is not like cohesive with the conversation. It's not following the natural flow. Might loosely feel like it's associated, but it's not. Or just completely derailing the conversation. Putting a halt to where it's at, switching to a completely different topic. This is not changing topics, but an actual unnatural flow of going from one subject to another. This could also be as extreme as their sentences are not making any sense. The words that they are saying are not making any sense. It almost appears to be like aphasia. Next is abnormal motor behavior or extreme disorganization. This could appear as irrational or unprompted outbursts like anger, laughing, crying, but these are extremes, they're unprompted, and also to like catatonia. Lastly is delusions. These could be numerous different, appear in numerous different ways, but for time's sake, just simply irrational fear of being harmed or harassed, thinking that others are against them, everything is coming against them. And this is not just negative, oh, I'm thinking negatively, but it's an irrational, they really feel like everything is pointed back to them negatively. They are fearful of an impending catastrophic event, health or organ-related irrational fears or suspicions. Any of these delusions cannot be convinced with proof. So even if there is extensive proof, you cannot convince this individual that these irrational thoughts are not, they're not true. You cannot convince them of that. Negative symptoms or characteristics could be like lack of eye contact, lack of social interaction, lack of being able to experience pleasure, or just diminished speech output. Not just I'm introverted, I'm not saying a lot, but they just do not speak very much. They don't speak. So like I said, every psychiatric disorder has, they pull from these characteristics to help make the diagnosis. One of the schizophrenia diagnosis in that spectrum is schizophreniform. And with that, to be diagnosed, these characteristics need to be pulling from delusions, hallucinations, disorganized speech, or grossly disorganized, or catatonic behavior and negative symptoms. But at least two of those that are diagnosed, they need at least two pulled from those areas that I listed. At least one of those two has to be delusions, hallucinations, or disorganized speech. Timing is very important with any schizophrenia diagnosis. We need to know the time frame. With the schizophreniform, it is going to be, it's lasted at least a month, but no longer than 6 months. Development in this, about a third of individuals who are diagnosed with schizophreniform end up recovering within the first 6 months, And those who do not recover will usually go on to be diagnosed with schizophrenia or schizoaffective. The prevalence in the schizophreniform is it's less likely in higher income countries than schizophrenia is. But both schizophrenia and schizophreniform are common in higher numbers in lower income countries. Next is schizophrenia. So schizophrenia, again, it's going to pull from those characteristics. The delusions, hallucinations, disorganized speech, or grossly disorganized, and of course the negative symptoms as well. Again, needs two of those, but at least one needs to be delusions, hallucinations, or disorganized speech. All of these need to be occurring significantly. Like it's not just, I think this is happening, but a significant occurrence within a month's time. All, like the two that are being noted, need to be occurring in addition with the negative symptoms within a month's time. There is a markedly low performance rate in at least one area. This could be workplace, home, self-care, relationships, and these disturbances overall will need to last at least 6 months. And that includes the month that the symptoms presented themselves. Which with treatment, sometimes some of the positive characteristics do diminish, but those negative ones, the lack of eye contact, lack of conversation, social interaction, flat affect, those are going to remain through that 6-month period. Those ones are not going to diminish with like medication and treatment. In the video that Dr. Tracy Mark published, What is Schizophrenia? It's More Than Hallucinations. Schizophrenia does, like those who are diagnosed with schizophrenia, they do not return to normal after an episode, but they have a chronic, like low baseline. Unless intervention, as far as like counseling or coaching is done to help with like the negative symptoms, those are going to remain. Those will remain there. If you think of other psychotic disorders like bipolar disorder, that you have a extreme high, extreme low, and those emotions and things that are happening, those delusions, or that a bipolar disorder person might experience, they're going to be tied to that major depressive episode or that manic episode, whereas a schizophrenic person is not. It's going to be across the board, and their delusions, hallucinations are not going to be tied to a specific emotion. It's just a baseline and something it's not connected to this specific emotion. And also, those with bipolar disorder tend to recover in between episodes, and maybe not completely, but they show very high signs of recovery. That even negative symptoms are gone, where schizophrenia is not. Those will remain. So the symptoms that they experience, there can be no substance abuse or medical conditions that can explain any of them. So those obviously need to be ruled out. They need to confirm that there's no signs of autism spectrum disorder or a communication disorder, like in early child onset. And those are the main. Those are the characteristics and where they pull to diagnose the schizophrenia. Now, prevalence. It can be correlated in some refugees or immigrant status, but it's a little bit difficult to calculate because of misdiagnosis in some cultures and some groups. But both sexes, male and female, appear to have the same effect equally of schizophrenia. It is rare for it to be in adolescence. with the onset of schizophrenia, with most likely in men in their mid-20s and women in their late 20s, with the general range of late teens to early 30s. The prognosis for schizophrenia can be hard to determine at onset. Usually it's a gradual incline towards progression. Environmental, cultural, socio-cultural factors, they seem to be a big indicator on the outcome and the severity of the diagnosis. Lastly is schizoaffective. It's also going to be diagnosed through those positive characteristics, the hallucinations, the delusions, disorganized speech, grossly disorganized, and negative symptoms. Again, 2 have to be pulled from that, but 1 specifically needs to be the delusions, hallucinations, or disorganized speech. Along with a major mood episode, either manic or depressive, but it needs to be extended and uninterrupted. So sometimes this can be confusing for bipolar disorder, but we'll kind of move into that. There are some distinguishing characteristics between this. There would also need to be a 2-week period in which the individual experiences the delusions or hallucinations apart from that major either manic or depressive episode. But the duration of the illness should be marked with symptoms of a major depressive or manic episode. So even though there is breaks in time where the manic or depressive episode isn't occurring, there should be hallucinations or delusions within those time frames, but canon throughout that time frame or throughout those episodes, there should be some symptoms showing either manic or depressive episodes, or major mood disorders, major mood episodes, I'm sorry. None of these characteristics or events should be connected to any substance abuse or medical conditions. These individuals who have these schizoaffective may have fewer negative characteristics like the flat affect, lack of eye contact, than those of that have schizophrenia. But there should be a noted decline in self-care and even like social restriction. So they're going to be a little bit more withdrawn and not taking care of themselves still. With the schizoaffective disorder, it is more common in women, and it makes up about 1/3 of the schizophrenia spectrum disorders. It is common for individuals to be diagnosed with a mood disorder first. So like I said earlier, possibly a bipolar disorder or something along those lines first, and then be diagnosed with the schizoaffective. It is important that with each of these diagnoses, there are specific modifiers and specifiers attached to these diagnoses. They give additional information surrounding that diagnosis that's specific to that individual. This could include with or without catatonia, what's the prognosis, how many episodes has the patient or individual had, and types of behaviors such as the bipolar, depressive, or schizoaffective. These additional modifiers are indicators that help track and maintain a full understanding of the diagnosis for that specific individual, so how it pertains to that individual. And that is it. I appreciate this. Thank you.